Thank you, Moira. It's a pleasure to be here. And if you just give me 1 second, I'm going to restart so my timer tells me exactly how much I have, so I don't go over. It's my pleasure to be here tonight. Excuse me if my voice goes a little bit. I've been in meetings all day long, and I've been talking since about 7:30 this morning. So I'll do my best to keep my voice active for you. When I was asked to do a presentation and give an overview, I thought about, well, what would you want to hear? So what I've tried to do with this presentation is talk a little bit about who we are, and then palliative care in terms of the new landscape that's emerging in Ontario, because it is changing how we provision care and the structures and systems that are in place. Looking at the landscape that exists, and then wrap up with a summary of some success factors that we've seen over the last couple of years, and then go into Q&A. And there's one item that I didn't put on the agenda, but I did put it on your chair. We have a couple of campaigns that we've launched in partnership with our national organization, and I'll wrap up by talking about them. Excuse me while I make this bigger, because the eyes are also a bit tired. I have 2 disclaimers. You can tell from my bio, I am not a clinician. I'm an administrator, I'm a risk manager by background. So I can't answer any clinical or medical questions. And the second thing is, I typically won't comment on the availability or lack thereof of services in specific groupings or organizations, because I let those organizations speak for themselves. So what I will talk about specifically are residential hospices and hospice programs, because they are the organizations that we represent. So in terms of Hospice Palliative Care Ontario, who we are, we were formed in 2011 when we decided to no longer be a divided movement, and we merged with the Ontario Palliative Care Association. They were an organization that had been around for 30 years. We came out of them 25 years ago, and now we've brought everybody back together. The Hospice Association emerged when we started establishing community hospice programs in the province. And over the last probably 10 years, the fact that we were fractured was working against us. My 3rd day on the job, I briefed the new Minister of Health, and the first question was, I don't understand, there are 2 of you. And who do you represent? And very soon it became, why aren't you one? So that we took that to heart, and we made the move in 2009 and started the dialogue, and we became one organization last year. So we're now the largest provincial palliative care organization in the country. And why did we merge? It was to create that unified voice in the province, to no longer be divided, and bring organizations together with the people doing the frontline service, so it made sense. We were the only province that had 2 organizations representing the same cause. So we now have about 481 individual members. We're growing by about 15% a year in the individual side, and that is from across the spectrum: nurses, physicians, social workers, bereavement counselors, educators, organization executives. We have about 215 organizational members, 95 of which are hospices. The rest are CCACs, LHINs, supplier organizations, some long-term care homes, some hospitals. And within the system, we have about 13,500 registered volunteers that have gone through a mandatory training program to become an in-home hospice volunteer. So that's a significant number in terms of the system in Canada, and they provide a lot of care, which I'll talk about a little further on. Our vision is to be the unified voice of collaborative, quality hospice palliative care. If you're in the healthcare system these days, collaboration, quality, excellence, integration are the words you hear every single day. So part of our job is to make that a reality so that it actually improves patient care. It's not just systemic change for the sake of change. And our mission is to provide leadership on behalf of our members by informing policy, promoting awareness, education, knowledge transfer, best practices in the pursuit of that quality care. So what is hospice palliative care? So, basically it's a philosophy of care that aims to relieve suffering and improve the quality of life and the quality of dying. It strives to help individuals and families address their physical issues, cope with symptoms, cope with the psychosocial, and it promotes opportunities for meaningful and valued experiences, and spiritual growth and self-actualization. The main difference in our philosophy is our aim of care is quality of life and not curative. So once you're in the hospice palliative care system, the aims are different, although we're trying to blend the two so that the philosophies overlap a bit. And generally, it's individuals that are requiring a focus of care that is around pain and symptom management and relief of symptoms and relief of suffering. So some of you may have seen, this has been around for a number of years. This is typically called a trajectory of illness. This is what it looks like. So you've got diagnosis on the left side there, and then it goes up until the person dies, and then the bereavement care after death for the families. Now, this model uses the dashed line to separate the therapies around modification or curative and therapies around relieving suffering. So the curative is on the upper side and the palliative care is on the lower. The model does include a footnote in the document that it comes from that it's not really a straight line, that it fluctuates based on the individual's need. But what does that fluctuation actually look like? This is what it looks like. And this is the new model that we're using in Ontario, putting palliative care within a chronic disease management continuum. So at some point on the left, there's an issue, and there's something at risk, and it's dealt with through primary care. There's a diagnosis made. Now, it may be that that diagnosis is not very optimistic. It could be somebody with advanced pancreatic cancer with an expected lifespan of 3 months, in which case they move very quickly down into this phase. Or it could be somebody that's diagnosed with chronic obstructive pulmonary disorder, or COPD, a disease of the heart, and they could be in this journey for many years. And my dad had COPD, and from the time we figured out that's what it was until he died was about 8 years. So, and during the early stages, he didn't need interventions. He just needed to hang out at home and do what dads do. As it progressed, he needed more support at home, and then eventually he ended up in a palliative care unit. The idea here, though, is that it's not that straight line, that people move in and out. There's fluctuations, and the care provision is based on the individual's need. We're also trying in Ontario to move the language away from being end of life, because people look at that and they automatically assign a time frame. So if you say, what's end of life in Ontario, depending on where you are in the system or whether you work in it, you might say, well, it's 30 days, it's 90 days, or it could be a year. We ask a question during admissions in a lot of programs to the physician, would you be surprised if this individual died within the next 12 months? And if the answer is no, then they're generally considered to be a palliative care client. So it is fluid, and it's very important that we look at this blue arrow that underlines there, which is psychosocial spiritual support throughout the entire continuum. Because hospice palliative care isn't just about the medical. It's about caring for the whole person and their families and their loved ones that are around them. So the original triangle is still there. We've just enhanced it to talk more about the difference in the movement through the trajectory. So in terms of care settings in Ontario, the first choice for many people is to die at home. And home could be their private residence. It could be a retirement home as opposed to a long-term care home. It could be a group home. It could be somebody that's living on the street or in a shelter. It could be somebody that's living in supportive housing, and it is often somebody that's living under incarceration in a prison or a jail. And our philosophy is that in any setting where somebody is expected to die, they should have access to a defined hospice palliative care program. The other community settings that we have are residential hospices, which are small facilities that have beds where people are admitted for the last sort of month of their life. Long-term care is a significant component of the system. They have a large population, which I'll talk about a little bit later. Supporting in the community, we're emerging interdisciplinary outreach teams. So teams of physicians and nurses and social workers and psychosocial workers that can go out and intervene in the home and support the primary caregivers or the families when necessary. These teams have had a tremendous impact on reducing hospitalization in the geographies that we've studied. So we have a number of teams that are being piloted in the Hamilton area, and they've seen decreases of up to 60% in the avoidable ER. Because most people go to the ER because they have a symptom that can't be managed at home. And often, the reason it can't be managed is nobody's put the resources in place, or that they've identified that that's the issue that's going on. So the teams are now mandated in all of the regions to be in place by the end of 2015. We also have in the province about 35 pain and symptom management consultants. These are nurses with many years of pain management experience, and they work to support other regulated professionals, doctors and nurses, in sorting out pain challenges for palliative patients. And then on more of the institutional side, we have complex continuing care, which has a large number of beds, and we have acute care. And in those settings is where people would go for specialty and tertiary expertise. So they may have an obstructed bowel that needs to be treated, so they need to be in hospital, and then they may be discharged following that. The specialty and the tertiary expertise is also needed to support in the communities, to support our primary care physicians. So I'm going to now look at sort of a brief overview of what the capacity is in the province right now. In terms of palliative home care in Ontario, the legislation that's in place defines how much the maximum amount of care per individual is permitted in the first 30 days, and for nursing it's in an average 7-day period. So for personal support workers, in the first month you can get up to 18 hours a week. And after that, you can get up to 14 hours a week. This is government paid for in-home care. These maximums may be exceeded for up to 30 days in extenuating circumstances. So normally, for palliative patients that are end of life, if it's very complex, they will put in more resources. In some cases, they might even put in 24/7. It's not the rule, it's the exception, but they have that flexibility. The challenge is the current legislation says that after 30 days, you have to stop. So we're often in this strange predicament of the patient didn't die fast enough. They've rallied, they've come out of that system. A month later, they're now actively dying, and we have to lobby to get that support back in. And so that's one of the challenges that we're working on. So in a given week, there's 165 hours. And you can have 14 hours of PSW after the first month, and you can have 48 hours of combined RN and RPM service. That leaves 103 hours a week that the family has to provide. So out of a given day, 14 hours is looked after by the family. And of course, not all people require 7-day-a-week care, 24 hours, and some people require minimal and others require no care. But that's the current system that we have. So the result of this is that the family has the biggest burden of care. In terms of beds, we have approximately 320 acute care beds in hospitals that are being used for palliative care. There's a big difference between this number, which we know because we did a survey, how are you using your beds, versus how many beds are funded and designated for palliative care. That's a much smaller number. But hospitals are doing this work out of necessity, so there's roughly 320 in the province. There's about 335 beds in complex continuing care, places like Bridgepoint and Toronto Rehab, that are being used for palliative care across the province. And then long-term care has about 75,000 beds in Ontario. residential hospices. A residential hospice is a facility that exclusively provides end-of-life care for the individual and support for the families. They range in size from 2 beds to 10 beds. And at present, we have 29 of these facilities operating in Ontario with a total of 219 beds. That number is as of December, I think, 15th is the last time we checked. We have another 13 beds under construction, and we have another 146 beds that are in planning throughout 17 different locations in the province. So if there's no further funding and everything gets built out, we'll have 378 beds in the province. And there's a little footnote, they range from 10 beds, 9 beds, 8 beds, 6 beds. The majority are 10 beds. That is the most efficient model in terms of staffing and operations. Most of the 10 beds are located in larger urban centers, and the smaller ones are located in smaller rural centers. The reason for that, our funding is at about 56% of the budget, and it's restricted to pay for the nurses and the personal support workers. So anybody operating a hospice, they're fundraising the patient food, the linen, the housekeeping and maintenance, and everything else. That works out to about $700,000 a year to operate 10 beds, plus $900,000 for the nursing, so about $1.6 million. So the total beds in the province, about 870 when you add those three up. And we're often asked, how many beds should we have? And the answer to that is not clear, because there's no modeling for Canada, really. There's 2 studies, or 2 models, but one is based on the other. So Australia did the first work around modeling palliative care beds, and they came up with a formula of 6.6 beds per 100,000 population. So based on Ontario's population today of 13.5 million, we should have around 905. However, in British Columbia, Fraser Health took the model and they applied it to the way things work in BC, and they figure for the same population you need just over 1,000. So the challenge in Ontario is we don't have any modeling that's specific to us. The population in Ontario is projected to be just under 20 million by 2036, which means we need about between 1,300 and 1,500 hospice palliative care beds for the population. And those beds are distributed throughout acute care complex and hospice. They're not all residential hospice beds. Now, also in Ontario, we have a very robust in-home visiting program where volunteers are trained to provide hospice palliative care in the person's home. They're supervised usually by a nurse or a social worker, and they provide respite. They're trained in lifts and transfers, physical care, to do legacy work, to be a companion, just to sit and play chess or to read a book or just to sit while the family goes out. But they receive a 30-hour training, which allows them to do pretty well anything except medical type interventions. We have 85 of these in the province, and they serve about 450 communities. That's where the volunteers are. On average, they're serving about 22,000 people a year, delivering to well over 700,000 hours of care now. And about 40 of them have day hospice programs. And the day hospice is a program where the patient or the ill person will go to a facility for the day, usually about 6 hours, to get them out of the home. They're typically people that are more mobile, and they have recreation opportunities, they have a communal meal. There may be complementary therapies such as Reiki or massage, and there are often peer support groups that happen. So you may have anywhere from 5 to 20 people that are coping with a terminal illness that will attend one of these programs. And it allows the family to have a sort of a full day of respite. Now, we took on a provincial policy review about a year ago with the ministry. And the reason we did that is there wasn't a policy in Ontario. Hospice palliative care was handled under different strategies and initiatives, but there was no central cohesive policy on what we should be doing about hospice palliative care. And because of that, our health authorities, so we have 14 regional health authorities that are called Local Health Integration Networks, or LHINs. So when I talk about LHIN, it's not a woman, it's an acronym for a bureaucracy. And of the 14, only 2 articulated palliative care as a priority. And we thought that was a bit problematic given where we are demographically and the demand for the services. So we formed a coalition in 2009, and the purpose of that coalition was to bring all the people that were working in palliative care to one table to pool all of our issues, all of our asks, and all of our advocacy, and write a single brief to government asking them to take action on the items that we agreed were the priority. So we did that, and this is what our coalition started to look like. So we call ourselves the Quality Hospice Palliative Care Coalition of Ontario. We mirror a national one, and my organization acts as the administrator, the secretariat for this. We have all the significant provincial level organizations are at the table. So people like Cancer Care Ontario, the College of Family Physicians, the End of Life Networks, Cancer Care Ontario, Ontario Long-Term Care Association, the Caregiver Coalition, the Working Group on AIDS and HIV Rehabilitation, Heart and Stroke, Alzheimer's, and we're adding more every day. The criteria is you have to be a provincial level organization. These organizations have a very large membership. So, my organization, we're about 690 total. There's 9,300 family physicians in the province. So it's quite a large reach. And the purpose is to work with MOH-LTC, which is the Ministry of Health, who are the policy setters, or the stewards of policy. They fund the health networks, and the health networks fund the service providers, which is this group of people over here. So the whole purpose of this is to centralize our advocacy. The reach of this, as I said, is quite large. So roughly a dozen organizations, and we have 6 academic centers, the universities that do palliative care research. That represents 900 organizations providing care, and we've got 10,000 regulated staff, 15,000 unregulated, and 14,000 volunteers. So that's a huge reach. I was really shocked when I put this slide together about how extensive it was. So why did we need this? We talked about it. It was disjointed. There was no policy. We were very siloed. Everybody operated in their own little silo. And I used to run a couple of hospices in Toronto, and clients would often say to my case managers, "Why are you asking me what's wrong with me again? Why are you asking me my diagnosis? Why are you asking me my age? Surely somebody has written this down because you're the 15th person in the last 2 months that have asked me these set of questions." So we're very siloed. And that's distressing on the families. They often don't know who's in their house. They don't know whether it's the personal support worker, the nurse, the hospice volunteer, the case manager, the regional case manager, the OT. It's very confusing. So the current model is also very targeted on disease-focused interventions, centering on curative. It's delivered by siloed organizations, and it's very, very end of life. So we're typically getting referrals into the palliative care system when somebody is less than 30 days away from death. And that means there's not a lot that we can do. I mean, there's some interventions, but to really tackle the quality of life issues and to help the family through the earlier stages, we need to be in much closer to diagnosis. So the proposed model is this model where we've got all of the individuals working, and there are teams within teams, but we're looking to connect them virtually. So there is some mechanism to bring together the pain team and the psychosocial and the occupational therapy so that they're all talking to each other and they all have an idea of who this patient is and what their needs are, so that anybody on the team can make referrals, they can address issues, and then there's a higher degree of information sharing. So the type of thing that we're looking at is comprehensive assessment, so one assessment, and that information shared. One interprofessional team, not multiple teams coming in. Basing what we do on evidence-based, preventative, proactive care. So, for example, we know that if someone gets 7 hours of nursing care in their last, I believe it's 90 days of life, they have a 35% less chance of having to go to the hospital. 7 hours of nursing care is a lot cheaper than an ER admit, because the average visit to ER costs the system $10,000 per visit, or 7 hours of nursing is $350, maybe $400. So there's lots of reasons why we're doing this, and one of them is cost. You know, it's not that we have to put more money into the system, but we have to be better stewards of the money that's in there. Because if we make the right decisions, we can save a lot of money further down the pipe, and we can put that into the community. So what was the outcome of all this policy review? It was very large. We had a number of tables. We had people from all over the province, from every discipline, every sector represented. We had a large cluster of separate caregiver focus groups. We were going to do the caregivers with us, but we found out that we talk in very cryptic acronyms, and we were moving very, very fast. So we thought that would be unfair to the caregivers, so we had a process that engaged them and brought their information in, and then they joined us at the end. We have an agreed-to document that the policy people, the ministry, the funders, the LHINs, and the coalition members who are the providers have agreed to. We have a shared vision now for hospice palliative care in the province. We're moving from focus on end of life to focus starting in the chronic disease phase. We've achieved a common roadmap to get to that vision, and we've identified shared responsibilities for carrying this out. We've not gone into government and said, here's the 100 things that you should do, and then gone away and waited for the money. We went into government and said, there's like 300 things we should do. Here's 100 that we've prioritized, and my organization is going to do some, you're going to do some, long-term care is going to do some, and collectively we're going to have accountability for this. So it was a very different approach when we did this work than what is common with government engagement. So we've come out with 6 broad stroke priorities. So number 1 is to broaden access to hospice palliative care and the timeliness of access. So earlier access in more settings. As I alluded to earlier, not everybody has access to hospice palliative care. In some regions, 1/3 of the people dying have access. And sometimes it's not for lack of service. Nobody has referred them to the system. And if they're not referred, they don't have access. I mean, it all hinges on that referral. We want to strengthen caregiver supports because caregivers deliver so much of the palliative care, and burnout is a major factor. So what can we do to provide supports, psychosocial, bereavement supports? How do we better coordinate to support caregivers? That's a major priority. Strengthening our capacity and our human capital, so our human resources, improving integration and continuity across the care settings. The whole purpose of LHINs was to integrate agencies. In the Drummond report, he made reference to the fact that it's a bit crazy to try to manage over 2,500 individual contracts with health service providers every year. That's a lot of bureaucracy, it's a lot of review. So the recommendation is to have less. That doesn't mean there will be less organizations, but the funding may flow differently. There are back office integrations and there are mergers happening. I took 2 tiny agencies, made them bigger, and then just before I left, I set them on a path to go into an even larger organization. So they're still a standalone hospice, but they have a huge administration that's standing behind them that they could never afford to have when they were small. So it's about building that capacity for sustainability. We also have to strengthen accountability. Accountability for the money and the things we tell government we will do, but also accountability to each other. If I'm the hospice on that side of the street, and you're the hospital on that side of the street, chances are we don't talk that much, and we should. We should look at the patient flow and how do we support each other? How do we support discharge from hospital? How do we bring earlier referrals? And how do we stop somebody who is 4 days from death from showing up at the emergency room entrance of a hospital that has a palliative care unit on the other side of the building? And I'm not kidding you. I've heard of nurses rushing to ER to intercept the gurney and get them into palliative care so they don't go through ER. Because once you go into ER, there's all the interventions that aren't necessary. And then the last piece of the puzzle is to build more public awareness, because even with 25,000 people getting home care and 75,000 in long-term care, people don't know about hospice palliative care. So often they say, I didn't know this existed. So we have to broaden that public awareness. This is very busy, but what I wanted to demonstrate here is that this is the Ministry of Health plan for moving it forward. But what's important here are these three bars, where it's the coalition of providers, it's the LHINs, it's the ministry, and some additional partners that are actually driving this. It's not any one. I was on a 2-hour call this afternoon with the federal, my federal counterparts and all the Ontario leadership, and they're looking at this model and elevating it up as a framework, because it's this collaborative shared leadership that is allowing us to move this work forward. We would still be sitting talking about policy had we used the old paradigm of government engagement back in September. So in terms of success factors, after looking at what works in the system and looking at some of the literature, when it's a systems approach and to deliver excellent care for the individual, you've got home care, which is in-home and in hospice, and all those other settings that I talked about. You've got those interdisciplinary teams that are connecting and supporting and acting as resources. You've got residential hospice, long-term care, complex, acute care. It's about getting the right care in the right time at the right place. Hospices have a very high capacity and a very high technical skill set. 5 years ago, if you were in a hospice, you had no intervention, so no tubes or anything like that. Today, we take patients that have central lines, intrathecal catheter, all kinds of interventions, because we built up our skill set. But we still now and then have to take that person and send them to the hospital for a treatment, obstructed bowel, or something more complicated, and then bring them back. The most important part of all of this is that, the resourcing has to be in place for all of these components. If a region decides, oh, we're just going to put money into outreach teams, we're not going to worry about residential hospice, what will happen is when anybody surpasses the ability to be cared for at home, they're going to present at the ER, and that's not necessary. An ER stay, as I said, is $10,000. Acute care beds are $850 to $1,200 a day, and residential hospice is about $440 a day. So, there's huge variances in the cost. So that's my overview of where we are in Ontario. I'm just going to talk very briefly about 2 campaigns that are underway. The first one is Speak Up, and we call it Speak Up Ontario because we had to change all the materials just for Ontario because we're different. All the other provinces have the same rules around substitute decision maker and consent. Ontario is just a little bit different. So what Speak Up is about is advanced care planning. It's helping people have the conversation early on. And this isn't when they've been diagnosed. This is me. This is people that are healthy, that, when you first get married, you plan for your wedding, you plan for your kids' education, you plan for your vacations, probably more than you plan for your retirement, and you plan for your retirement. Nobody plans for the death. And only 2.5% of deaths in Canada are sudden. So if you think you're going to go out with the bus hitting you on your way to Starbucks, chances of that happening are very, very slim. That's 2.5%. The vast majority of people go through some other type of illness. And so we should be planning. So Speak Up Ontario is it's a website and it's a set of resources to help have that conversation. We ran a campaign at Thanksgiving called Let's Talk Turkey. We tried to use the moniker, the turkey didn't have a choice, but you do. But it didn't go very far. So we ended up just, Let's Talk Turkey. But it's that choice in making your decisions about what type of care. One of the misnomers in Ontario is you cannot write your wishes down on paper. A doctor in Ontario is not legally permitted to take instructions from paper. They have to take it from a substitute decision maker. And if you're married, then it's your spouse. There's a hierarchy in the legislation, or it's somebody you designate. But if you don't have anybody, or you're estranged from your family, that gets complicated because then the trustee has to step in. That's it just went into my head. The Board of Trustees. Well, no, it's the provincial, there's a provincial organization, the Consent and Capacity Board, which is a bureaucratic process. So in Ontario, you have to designate somebody as your substitute decision maker. If it's not your spouse, then you have to write down who that person is, or it'll go through this hierarchy. So, I don't want that burden on my mom. A lot of people don't want to put that burden on their family. So I have a friend that's designated to make my decisions if I'm ever incapacitated. And then I sit down with that friend and I say, here's what I would want and here's what I wouldn't want. And I explain to them my wishes, and then I pray they'll listen to me. Because once I can't make my decisions, they make them for me. So choose wisely who those people are. So that's how it works in Ontario. So this is a campaign to have those dialogues and get that information out. The other campaign that we've launched is this one, which is let's talk about hospice palliative care first. The reason this campaign was launched, and this is only about 3 weeks old, this is in response to the dialogue that's happening across the country about assisted suicide and euthanasia. The palliative care community is not polarized in that argument. They're split. So we don't have a majority pro or con. It depends where you go in the province and the country. So both nationally and provincially, we've taken the opinion that yes, there needs to be vigorous public debate about that topic, but we are not that. Hospice palliative care is not assisted suicide and it's not euthanasia. It's quality of life and it's services, etc. So our campaign is to talk about hospice palliative care because people that are faced with life-changing prognosis, they're confused and they're worried. What's going on? What are my options? And all they hear is this assisted suicide talk. So it's confusing the conversation about hospice palliative care. I had somebody in my office 2 weeks ago that was pro-assisted suicide, and they just assumed that when they wanted to die, they would go to a hospice and we would put them down. Well, I rest assured that no hospice is ever going to do that because that's not what they're about. And they don't want to get confused with their mission of providing quality of life and end-of-life care with becoming euthanasia centers. So our campaign is to have that dialogue about what is palliative care. We've got a couple samples out there, but unfortunately there's no printed material with this campaign, but it's all downloadable. You can print all you want. We just couldn't pay for it. It's getting more and more expensive these days to print things. So this is a campaign that is being run nationally through our federal organization, but we've endorsed it here.